morning and welcome to our session. My name is now Shoji, and I am honored to serve as a moderator for this session. So this session, titled Patient Selection Panel, is dedicated to selecting appropriate candidate for focal therapy. We will share clinical experience and engage in discussion. So let us begin with our first presentation. So our first speaker is Dr. Ardalan Ahmad, an assistant professor of urology at the University of Manitoba, Canada. Please start the presentation.
Perfect. Good morning, everyone. Thank you for the introduction, and it's exciting to be here and join you for these talks today. I had briefly went over my presentation yesterday, and I basically today focusing on consensus statements and how it evolved over time. I have no relevant disclosures for this talk. The objective of the study, as I mentioned earlier, is to go over the available consensus for the past decade and also review the most recent consensus that was published earlier in the year. These are the list of the consensus that I'm be briefly going over. And that being said, I think all of us agree that the key to success for any treatment for prostate cancer is patient selection, and this is true for focal therapy as well. If I want to summarize what is the ideal patient for focal therapy, it would be a man who's expected to live at least 10 years. They are willing and committed to continue with their surveillance, including PSAs, MRIs, and imaging, and possibly biopsy after treatment. They have to have a visible lesion on MRI, which is confirmed to have grade group 2 or 3 disease on biopsy, and preferably the lesion should be solitary on one side away from vital structures, and MRI doesn't show any adverse features. With any treatment decision for prostate cancer, there are multiple variables to consider, but to categorize them, it comes down to what the patient wants, what is their life expectancy, and what the disease dictates. The best way to come to a decision, in my opinion, and I think everybody agrees upon that, is to involve the patient, have them basically be part of the team, come up with a shared decision making, and it has also been shown that in the future, chance of regret for the decision decreases when you have shared decision making with the patient. So how about the guidelines? I think the first two talks briefly went over this. As of now, none of the guidelines suggest primary treatment of prostate cancer with focal therapy. However, the AUA guideline and EAU suggest that in select and well-informed patient with intermediate risk disease, you may consider offering them primary gland focal therapy as part of a prospective registry or clinical trial. NCCN obviously currently does not recommend focal therapy and just suggests focal therapy in cases of salvage treatment. Excuse me. So I'm going to summarize what are the patient characteristics, what's the modality of choice for diagnosing the patient, how to do the biopsies, and basically are there any differences between the modalities we have. So we focus on age quite a bit, but over the years we have come to realize age is just a number. It's actually more important to know how your patient is doing overall. So performance status and how long they're expected to live is now highlighted by many of these statements that is important. So the most recent statement suggests that age should not be a determinant of focal therapy, or rather life expectancy should be calculated before suggesting focal therapy to a patient. Most experts suggest that at least 10 years of life expectancy should be considered when offering focal therapy treatment. How about other patient characteristics? Obviously, as I mentioned, it's important to get your patient involved in the decision making. If a patient desires to protect their sexual function or urinary function or minimize the side effects of treatment, obviously you should prioritize focal therapy and offer it to them if from a clinical standpoint it's a good decision. Having LUTS and severity of LUTS does not affect the option of undergoing focal therapy, as does the gland size. In fact, the most recent consensus suggests that if you can reach the lesion and treat it adequately and safely, the gland size should not affect your decision to offer treatment for focal therapy. How about imaging? I think across the board in the last decade with the invent and increasing role of MRI in our practice, all consensus and all experts suggest that multiparametric MRI is the modality of choice. There are new modalities that are kind of being investigated, including the PSMA PET scan and also micro ultrasound, which currently are considered investigative and are not suggested to replace the MRI. One important statement is that if you cannot see the lesion on the MRI or the quality of MRI is poor, you should not consider focal therapy for your patient. How about biopsy strategies? There are a number of ways to do the biopsy. I think, as Tom just mentioned, target biopsy alone would likely cause you to miss about 10 to 20% of clinically significant cancer. So in most guidelines, they suggest that you should combine the targeted biopsy with systematic or saturation biopsy to avoid understaging your patient and avoid out-of-field failures and basically selection failures. The most current guidelines suggest that for each visible lesion, you have to at least take 3 or 4 targeted biopsy and combine it with 10 to 12 systematic biopsies. Any type of targeted biopsy, including in-bore MRI biopsy, MR ultrasound fusion, or cognitive biopsies are considered adequate. As far as disease characteristics, we briefly touched upon this earlier that in about a decade ago, maybe 2 decades ago, focal therapy was considered an alternative for active surveillance. But over time, we come to realize that focal therapy is more suitable for patients who have clinically significant prostate cancer, namely grade group 2 and some of the grade group 3 patients. And some people actually suggest that focal therapy is active surveillance plus. So right now, most guidelines suggest that treat that patients with grade group 2 or 3, do not offer focal therapy to grade group 1 or grade group 4 or 5 patients. PSA threshold used to be 10 or 15, but currently most of us actually agree that up to PSA of 20 that puts patient at intermediate risk group can be considered still for focal therapy. Finally, the role of genomics. As of now, there is no suggestion to routinely offer genomic markers for patients who are considered for focal therapy, but the result of genomic markers may affect your decision to offer focal therapy to the patient. For example, a patient with BRCA mutation should not be offered focal therapy. And finally, when it comes to energy source and modality that you want to treat, there is no difference or there is no recommendation regarding one compared to the others. As long as you're comfortable with the modality you're using, you can reach the lesion and safely treat it with a safety margin. That's the modality you should choose. And obviously, having access to multiple modalities gives you more options to offer to your patient. With that being said, going back to one of my first slides, so life expectancy is important. Try to offer the treatment at this time to patient who is expected to live at least 10 years. Make sure they are willing to commit to the lifelong surveillance. MRI is critical, and as of now, the only modality of choice to use for screening for focal therapy and planning your focal therapy. MRI alone is not adequate for offering a focal therapy, and you should confirm presence of grade group 2 or 3 disease in an MR visible lesion before offering them focal therapy. And preferably, it should be a single unilateral lesion well away from your vital structures and no adverse features on MRI. And once again, I think it's important for everybody to join our society. We are pushing forward. We need numbers and efforts. So please join us. This is the link. If you need help, I'll be happy to help you as well. Thank you.
Well, thank you very much. Great presentation. If you have any questions or comment from audience. Oh, okay, please.
The question, to me, in a rapidly changing field like this one, guidelines are not very studies that are often published 5 years ago, and the data from those studies may have been collected 10 years ago, and it's a completely different world now. So just really just a comment and kind of a question, because I think if you look at the guidelines, they don't reflect the excitement and the confidence that the focal therapy groups feel about the current and future status of focal therapy. They're very cautious, you know, under right circumstances, maybe, and it's an option. And I just want to kind of reinforce that I think the guidelines here fail us because they really look back and not forward.
I totally agree with your basically assessment and comment. Obviously, all of us are here to push the envelope and find new ways to treat patients with less side effects. We should not rely on guidelines. That's why focal therapy has been established as a society. We have to push and increase our presence in the guideline committees so we can push for it and basically come up with guidelines that are reflecting what's going on currently in clinical practice.
Okay, please.
I'd like to endorse what Laurie just said, but also mention something that Laurie's taught me recently, that there's a concept called wriggle room. And I don't know if you understand what he means by that, but wriggle room means that if something goes wrong with your focal therapy, you've always got a backup. And the indications and the selection that you've put forward really give us wriggle room. So if you treat something with focal therapy and it comes back, you've got something to do without compromising their cure rate. And I think the reason why we don't do Gleason 4+3 with cribriform and intraduct tumour, because you've got no wriggle room left in that particular tumour. And I think that concept, which is Laurie's, of wriggle room, is a really important one. It's just a comment about patient selection.
Thank you.
Okay, so thank you very much, Dr. Ahmed.
You're welcome. Thank you.
Thanks. I think in the interest of time, we'll press on, but please keep those questions coming. They're really good. It gives me great pleasure to introduce our next speaker, Dr. Law Yen Mee. Dr. Law is a very close friend and colleague of mine. I think we meet more often for coffee than for work. She's a senior consultant radiologist at Singapore General Hospital and the Deputy Director of Body Imaging at the Department of Diagnostic Radiology at SGH. And she brings with her a vast wealth of experience that spans 2 decades. We always joke that she's really the reason why PIRETS took off in Singapore. She really spearheaded our biopsy program together with the multi-parametric MRI. And she's also the reason why our biopsy program has a very high accuracy of 93%. So without further ado, please welcome Dr. Law. And she'll be talking to us about DAO AI for PIRETS. Dr. Law, please.
Good morning, and thank you, Kenneth, for the introduction. So if the previous talk on consensus is looking backward, then we'll try to look forward with this 15-minute talk. So is AI transforming MRI-based prostate cancer detection and selection for focal therapy? So I'll try my best. I'm not an expert in AI, but I know a little bit. So we know prostate cancer is extremely diverse and complex. So if MRI and PIRETS, these are the gold standard for prostate cancer diagnosis, but we know that it has highly variable performance and PPV. This is widely published in the literature, and this is especially so when we compare the expert centers as well as the community practice. So the expectations and the applications of MRI and PIRETS have evolved from initial staging detection of prostate cancer. Now we use it for prognostication models, and now we are also using AI in prostate MRI, which is a really hot topic. So in early days, we do this post-biopsy MRI to stage for cancer. It is not ideal, it is not accurate. And then we find this extraprostatic extension on the left. And with PIRETS version 2, we can now detect this cancer and target this cancer for biopsy. And with DCE MRI, we can detect the cancer with greater sensitivity, And now we are pitching the AI against the radiologist in detecting the cancer. And now we're using it for lesion segmentation, gland segmentation, as well as to prepare a 3D model for research purposes. So this is the evolving landscape of MRI and PIRATS. So how is the performance of MRI prostate like? So in this paper, which is published in Radiology in 2020 across 26, and these are expert centers, mainly in the North America, by the radiologists in the Society of Abdominal Radiology, and these are their results. The top graph is a PIRATS 3 and above lesion. The bottom graph is the PIRATS 4 and above lesion. And if we look at PPV of 0.5, we can see that most of these 26 expert centers are struggling way below 50%. And if we look at the results, so even for PIRATS 4 and above lesions, the PPV is only 49%. And this is, some people may say this is as good as tossing a coin. So if we were to extrapolate these results from the expert centers to the ambulatory practice, then we expect them to be doing much worse. So then can we use AI to improve the performance of this gold standard examination for prostate cancer? So what are the critical steps in this MRI guided pathway? So these are the steps and these are the personnel involved. So in the area of AI, there is a lot of research and it is very hot in these two areas where we want to use AI to detect the lesion as well as to segment the lesion for biopsy. But for this image-guided pathway to really work well, I think the first step is critical, and that's the image quality. And we want to ensure we have excellent image quality. This is especially so important in the area of focal therapy. So this area is relatively underdeveloped in this AI, but there are more and more studies and more algorithms now that are trying to improve the image quality of the MRI prostate. So this paper is recently published hot off the press in Radiology 2024, where we evaluate this biparametric AI algorithm developed by my mentor, Dr. Baris Turkby in NCI with his team. And we work on a diverse data set of biparametric MRI without DCE MRI and look at the impressive results of the AI. For participant level, is looking at sensitivity of over 90%, PPV of 88%, and this is doing much better than any of the expert centers that we see in the previous paper. And even for participant lesion level, it is doing very well at 60%. Cancer detection rate for significant cancer for AI is 96%, pitched against expert radiologist Dr. Turkby, which is 98%. And PPV for significant cancer for AI is 47% against the radiologist of 51%. So this algorithm is extremely promising and is doing very well, and is probably doing better than a lot of the radiologists in the routine practice. So this is an example of this algorithm. There are two lesions that are detected by the radiologist. The one on the right is a PIRATS 4 lesion, and the one on the left graded by the radiologist as a PIRATS 3 lesion. AI algorithm picked up the right-sided lesion. Both these lesions are biopsied, and we can see that the right side PIRATS 4 lesion is positive for Gleason 7 cancer, and the left side lesion is negative. So in this example, the AI is more sensitive and more specific with higher PPV as compared to the radiologist. In this second example, this set of MRI read by the radiologist is negative, so it's PIRATS 2. But AI algorithm picked up this significant cancer on the left, and this was then biopsied, and this lesion turned out to be a Gleason 7 cancer. So AI is actually more sensitive, more specific, and higher PPV than the radiologist in this example. This other example for this algorithm, there was no lesion detected. The radiologist picked up this lesion at the right posterior peripheral zone, which looked like a PIRATS 4 suspicious lesion. And when we biopsy this lesion, this is a true positive PIRATS 4 cancer. So there's a true negative here, there's a false negative here by the AI algorithm. So what about the use of AI in image quality assessment? So T2 weighted image quality is extremely critical, especially in focal therapy. Why do we use T2? We use it to detect the lesion, we use it to stage the cancer, we use T2 to segment the gland and segment the lesion for guided biopsy, and we use T2 to register the gland for fusion biopsy. So what happens when the T2 quality is poor? This can then result in misdirected, meaning you miss the cancer, or even worse, unnecessary biopsy when it is a false positive. And as a radiologist, if I can have an AI to improve my T2 weighted or to detect poor image quality, it has great potential to improve my workflow and patient experience, because my radiographer, when the patient is on the scanner, will immediately be told by AI, hey, this is poor quality, please reacquire, and this can be done on the spot. Whereas if I were to open the study and report a few days later, I will have to start the process to recall the patient, to bring the patient back, which will really reduce our productivity, and this will lead to poor patient experience as well. So in this paper, which I participated in with Dr. Turkby and his group, we looked at this deep learning-based T2-weighted image quality assessment algorithm, and we see its impact on prostate cancer detection rate. So prostate cancer detection rate is the single most important endpoint in any image-guided cancer detection pathway. So in our results, we showed that for PIRATS-4 lesion that's detected on MR, for the set of high-quality images detected by AI, the cancer detection rate is very high at over 50%, whereas it is much lower at about 30% in the patient with low-quality image. As for patients with normal, what we think is a normal set of MRI, if it is a high-quality MRI, the true negative prediction is actually very, very high compared to a set of poor-quality images in which you can get more than 10% of significant cancer in these poor-quality images. So T2-weighted image quality, therefore, affects biopsy outcomes, which is extremely important to urologists as well as the patients. And the main problem for the quality of T2 is actually motion artifacts, and in the case of prostate is rectal peristalsis. So there is a high detection rate in what seemed like a normal MRI when the quality of MR is low. And when we perform targeted biopsy with high-quality images, we have a much higher cancer detection rate. And this is a critical piece of information for us. So this set of images, for the set of images that are deemed by AI as high quality, for that PIRATS-4 lesion on the right, we get the cancer in both the targeted and systematic biopsy. But for the set of images that are deemed low quality by AI, there is clearly a PIRATS-4 lesion at the left posterior peripheral zone, but this was missed on targeted biopsy and it was only picked up on systematic biopsy. So what about the use of AI in the detection of residual cancer on MRI post-focal therapy? So this is an undeveloped area, and I don't think there are actually many papers at all looking at this. But with Dr. Turkby and myself, we use this biparametric-based AI algorithm, which I showed earlier, which was actually trained on a diverse data set of treatment-naive patients. So this AI algorithm has not seen any post-focal MRI. And when we run this algorithm on the post-focal MRI patients, you can see that the sensitivity is 47%, which is actually pretty respectable for something that's not trained, although the specificity, PPV, and NPV is low, which is expected. If we compare this sensitivity number to some of the MRI that is published in the literature for post-focal therapy cohort, a lot of the radiologists are reading at a sensitivity of below 50% as well. So there is a great deal of potential for this algorithm if we were to train it adequately on a set of post-focal MRI, and we will have to wait to see what this brings us in the future. So this is a patient with post-focal therapy in this cohort that we assessed with AI. He has right side focal ablation. Cryotherapy was performed. No, sorry, left side. And on the right side, one can clearly see a suspicious lesion here, which the AI accurately picked it up. And this shows restricted diffusion, which is suspicious, is at least a PIRATS-4 lesion. And AI therefore successfully detect this lesion, assign a PIRATS score, as well as accurately segment the gland and the lesion for targeted biopsy. And this is presented at AUA this year. So what is my wish list for AI-driven prostate cancer care as a radiologist? So this is my good friend, the AI algorithm. I wish that the AI will be able to pick this PIRATS-5 mass at the anterior transition zone. She will then segment the gland and the lesion for biopsy. And when I click another button, they will get my very nice report, which is very accurate, and I can just accept it. And the urologist can then get the model and will target the lesion for biopsy. And nice specimens are obtained from this nicely done model, sent to the pathologist, and the pathologist will then find all the cancer that the patient has, and the patient can therefore get the treatment that she requires. So whether I am admiring sunset in this beautiful monarch here at the big island of Hawaii, this is a very nice, that's the best picture of sunset I've ever had. And this monarch here is believed to be the largest mountain in the world, larger than Mount Everest if you measure it from the seabed. And this is the cloud. So this is really on cloud nine, lovely, lovely sunset. Or whether we are chasing our rainbows in the rest of the world, this is a family and I in the big island of Hawaii, chasing rainbows, whales, and fishes in the Pacific Ocean. or doing a coastal hike in the northeastern tip of Hokkaido. This is the Sea of Osh, which is right next to North Korea. With my eldest daughter, we love hiking. Or in the mountains in Hong Kong, the good friend, the AI, will continue to deliver this excellent patient care, and the patient can continue to receive treatment no matter where we are living life in the rest of the world. Before I end off, I think AI has thrown us a lot more questions than we know. How does this black box in AI works? Where are we heading in AI? What should we do with AI? Some people may ask, why is AI replacing me and when am I losing my job? So will we lose our jobs? No, I don't think so, because AI models are unstable, and very subtle changes can often derail the performance, and often we do not know why this happened. And that is when interaction with humans, the urologists, radiologists, and whoever involved can then help to do this better, and we can harness the technology of AI to improve our patient care. And we can definitely delegate routine tasks to AI. AI is extremely good in doing tasks like gland segmentation, prostate volume calculation, PSA density, etc. And then we can then free up more time to do value-added tasks like looking at complex cases to improve our patient care. Strong AI models can be developed, however, they need large, diverse, robust training data sets, and they need to be validated. And a lot of times AI is good in focusing on one problem, but cascaded deep learning AI algorithms have the potential and the ability to handle multiple problems. And many AI models currently handle unidimensional data such as the imaging data, and they do not look into other non-imaging markers such as PSA, any old images, treatment, etc. So with adequate interaction, I'm sure we can harness AI to improve patient care for prostate cancer patients, whether it's in focal therapy or radical treatment. So before I end off, I need to acknowledge my dear friend and Dr. Turkby, who is a senior clinician at NCI and currently a director of AI resource in NIH. So this was us when we caught up 2 years ago after COVID, talking about more collaborations in AI. The second picture was me 10 years ago, exactly 10 years ago, learning all about MRI, prostate, and PIRETs from the masters, Dr. Turkby and Dr. Choiki, for which I'm still currently feeling extremely blessed and grateful to. And the last slide was when we were presenting all our translational AI research projects at RSNA in 2024 last year. So with that, I thank you for your attention.
Thanks very much. And we've got a session, we've got 15 minutes at the end for questions for all of our speakers. So our next speaker is Dr. Sanjit Ghai. He's a professor in the Department of Medical Imaging at the University of Toronto and Director of Research at Joint Department of Medical Imaging at the University Health Network, Mount Sinai Hospital, Women's College Hospital. He leads a highly talented multidisciplinary team of radiologists, urologists, pathologists, and scientists at the University of Toronto with the MR-guided interstitial laser thermal therapy and MR-guided focused ultrasound ablation for prostate cancer. And his primary research focus is in prostate imaging and intervention. He holds the Trachtenberg Hack Research Chair in image-guided prostate therapy. So thanks very much, and he'll be talking to us about micro ultrasound. So thank you.
Thank you so much for the kind words and the introduction. It's a pleasure to be here this morning, and I'm going to be speaking on micro ultrasound in patient selection for focal therapy. So there's not much direct data on micro ultrasound and patient selection. I'm going to give an overview of micro ultrasound, discuss how it compares to MRI, and then allude to where we think it may have a potential role in patient selection for focal therapy. These are my disclosures in relation to micro ultrasound. Right, so micro ultrasound is a novel ultrasound platform which maintains the workflow of regular ultrasound. It operates at 29 megahertz, so it's got 3 times the resolution of the general ultrasound platforms, the trust platforms that we've been using for many, many years. And it provides resolution down to about 70 microns, which is the size of a prostatic duct. The higher density of crystals in micro ultrasound allows for the higher resolution. So you're looking at 512 kind of crystals as opposed to 128. And that's where the higher resolution down to 70 microns comes on the micro ultrasound. And if you look at the scientific basis for micro ultrasound, the conventional ultrasounds, with the conventional ultrasounds, the trust platforms, you're able to see about 15% of the prostatic ducts. But with micro ultrasound at the 3 times of resolution that it provides, you're able to see about 95% of the ducts. And so this ductal changes in the ductal architecture is the likely reason for the improved kind of detection and the resolution of micro ultrasound compared to the conventional trust platforms that we've been using so far. Here's an example that I shared yesterday as well. On the left-hand side, you have a conventional ultrasound image. In the middle image at the top, you see the micro ultrasound image, 3 times the resolution. You kind of appreciate the architectural distortion. It's kind of a mixed echo pattern, easily missed on the conventional ultrasound. If you look at the MR, there's perhaps a bit of restricted diffusion, but you don't see much on the T2-weighted imaging. This was actually grade group 3 on targeted biopsy. And here's another example that was in our study. You can see the lesion in the left, on the right side of the apex on MR. There are 2 lesions in the interior and the posterior aspect of the peripheral zone. And you clearly see the lesions on micro ultrasound. And you can appreciate that the ducts kind of, there's an interruption to the ducts, and that kind of brings your attention to the side. You know that, this is kind of a mass-like lesion, and these were both the interior and posterior. On targeted biopsy were grade group 2. And it's not just hypoechoic lesions, right? So our learning with micro ultrasound over many years is, if you see a hypoechoic lesion, you're suspicious that this may be cancer, and you target that site. So not all lesions are hypoechoic. The starry sky pattern, as you see on the right-hand side, this was grade group 3 with cribriform pattern. And then the smaller lesion on the image at the bottom, you see that there is a hypoechoic rim, but the central part of the tumor itself, the lesion itself, is kind of iso to mildly hyperechoic. And so you kind of start seeing these kind of, textural changes with the higher resolution that micro ultrasound provides, and then you can target these sites as suspicious micro ultrasound targets. It is a linear probe, so it allows you to do the biopsy both transrectally as well as transperineally. And I personally have been using it predominantly trans, but in the recent past, I've kind of moved over to transperineal biopsies with the micro ultrasound device. The other benefit of micro ultrasound, I would say, is many of the MRI lesions, so when you're using it with MRI, many, if not most, of the lesions are actually going to be visible on micro ultrasound. And so you don't have to rely on fusion for accurate targeting. If you can see the lesion in real time, you're more confident of hitting the lesion if you're using micro ultrasound for the biopsy following an MR. I'll move on to some clinical evidence that we have so far with the micro ultrasound system. Looking at publications with MRI, so these are publications where the operator had the knowledge of MRI. MRI had been performed prior to MRI. In this study, the first study on the left-hand side is a study from Cleveland Clinic, Dr. Eric Klein's group. 67 patients were included in this study. Not all of them had an MRI. And there was a distinct advantage, increased detection of clinically significant prostate cancer on micro ultrasound compared to systematic as well as some MRI-targeted biopsies. 19 men had an MRI in the study, and in 2 of those 19 men, micro ultrasound targets identified cancer that was not seen on MRI. And similarly, the second study on your left-hand side of the screen there, 13% of patients, or 20 out of the 159 men in the study, had negative MRI-targeted biopsies, but clinically significant cancer was found in micro ultrasound targets. So again, an added benefit, an incremental benefit, which may help in patient selection when we kind of allude to focal therapy patient selection. Further study, this is from Dr. Kennard's group in Edmonton. Again, on a lesion level, there were 15 clinically significant cancers that were diagnosed by micro-ultrasound cores and not detected on MRI. So, we know that MR is very good. It's the standard imaging tool for detection of prostate cancer. But at the same time, we know that its negative predictive value is not 100%. So when you use micro-ultrasound with MRI, the chances are that you're going to start picking up more clinically significant prostate cancers. Two studies where patients went on or were taken to micro-ultrasound guided biopsies following a negative MRI. So the MR was negative, but a high clinical suspicion of prostate cancer. And the first study done by Dr. Lugazzani's group in Milan, you'll see that the biopsies were done within 6 months of the MRI, so a short interval between the MRI, and a significant proportion of men harbored clinically significant prostate cancer. And after 34 men who had disease, 33 were identified on micro-ultrasound targets and not on systematic biopsies. So again, showing that there's going to be a benefit of using micro-ultrasound with MRI. And then a different study whereby negative MRI patients were taken either to conventional truss biopsy or micro-ultrasound biopsy, and we found that the cancer detection rates were higher in the micro-ultrasound arm compared to the conventional truss. Again, an added benefit to MRI. I did mention about micro-ultrasound visibility of MRI lesions, which kind of allows for real-time targeting instead of relying on a fusion system. And I'll highlight two studies here. This is a study done by Francois' group in Paris a few years ago. And if you look at what I've highlighted, there were 127 lesions on MRI, and 114 of them were actually visible on micro-ultrasound, knowing where to look. So about 90% of the lesions were visible on MRI. And that, again, improves the quality of your targeting rather than relying on a fusion system to enable targeting. And then the second study done by Raphael's group when he was in Paris, Dr. Salas Sanchez's group, men had an MRI and then went on to have either a fusion biopsy with a conventional truss or to micro-ultrasound targeted biopsy. And while the incidence or the detection of clinically significant cancer in the random or the systematic biopsies in both the arms was similar, you'll find that the targeted biopsy yielded more clinically significant cancer in the micro-ultrasound arm, again showing that it enables better targeting in the kind of similar cohort of patients. And then looking at some of the studies which were done in a relatively blinded fashion to the MRI, these were all those single-arm studies. But micro-ultrasound and MRI were interpreted by different operators independently. And again, I'm highlighting 4 studies here, all the studies showing that micro-ultrasound was non-inferior to MRI. And subsequently, there have been 3 meta-analyses as well, which kind of reinforces the fact that micro-ultrasound was non-inferior to MRI in detection of clinically significant prostate cancer. This was a study that we had done at our site a couple of years ago, and I'll show some of the data. 100 patients were accrued. The incidence of clinically significant prostate cancer in this cohort was about 40%. And as I said, MRI and micro-ultrasound were interpreted independently by different operators. And if you look at this, the incidence, the lesions that were or the clinically significant prostate cancer that was detected by the 2 modalities was similar. The difference was not much between the 2 modalities. Out of the 38 cancers, at a patient level, 33 were picked up on micro-ultrasound targets, while 37 were picked up on MRI. But we did find that the specificity was low. In our study, there were lesser number of patients who could have avoided a biopsy by micro-ultrasound in comparison to MRI. At the same time, we found that independent and blinded to the MRI, micro-ultrasound actually was able to see about 2/3 of the lesions that were seen on MRI. Here's an example from our study. Dense calcification, we know it's always going to be a problem with ultrasound to visualize the interior aspect of the gland. And of course, in this patient, there was a very big tumor that was missed on micro-ultrasound. But at the same time, I'm going to show another example, negative MR, even retrospectively, you really don't see anything on the MR. but there was a significantly sized lesion that was seen on microultrasound on a targeted biopsy. This was grade group 2, and in fact, this patient also had a lesion on the contralateral aspect, which was seen on microultrasound, and again was grade group 2 on targeted biopsy. I'll mention about the Optimum trial. Actually, Dr. Laurie Klatz is the PI of this trial. It's an ongoing trial. It's the first randomized trial comparing microultrasound to MRI. It's a 3-arm study. One arm is microultrasound only. The second arm is MRI and microultrasound, and the third arm is MRI only. So following the MRI, the patients go on to conventional kind of fusion biopsy. And we hope that this 3-arm multicenter RCT is going to provide us level 1 evidence for use of microultrasound in prostate biopsy. And we're accruing patients at this time. So to summarize, multiple studies have shown that microultrasound provides comparable detection to MRI. And importantly, I'll mention that it definitely has an incremental benefit when used with MRI, and therefore may have a positive impact in patient selection for focal therapy. Thank you so much.
Thanks. Thanks very much, Dr. Guy. I'd like to introduce my co-moderator, Kenneth Chen from Singapore General Hospital. Kenneth's academic output includes medical education as a clinical lecturer at Yung Lung Lin School of Medicine and Lee Kong Chian School of Medicine, as well as a clinical associate professor with Duke NUS Graduate Medical School. He has a research interest in basic science and as well as translational and clinical components in the area of uro-oncology, as well as novel device development, with a grant working on a novel drug-eluting ureteric stent for strictures and tumours. His other area of interest, which is relevant for today, is in the field of prostate cancer diagnostics and metastatic prostate cancer. So I'd like to thank Kenneth for his talk.
Thank you very much for that kind introduction. So very quickly, these are my disclosures. So this will be the outline of my talk. Firstly, I'll speak about the evolution of PSMA PET, and then move on to the current data, looking at combined imaging. And then we'll talk about a little bit about synchronous read versus PET MR, which is really quite exciting, an exciting topic right now, and conclude with some future perspectives. So most of us will be familiar already with the molecule, but here's a quick recap. As its name suggests, PSMA is a protein that is lodged in the membrane of the prostate cancer cell, with both intra and extracellular components, although it's the extracellular component that predominates. And it serves as a very good biomarker for various reasons. Now, firstly, it is clearly upregulated in prostate cancer. And secondly, its intensity also correlates well with tumor aggressiveness. Now, despite its name, it can be found in other tissues, but in much smaller, lower concentrations, such as in the small bowel and the salivary glands as well. As you can see on the PET scans here, there's physiological uptake in these areas. But perhaps the best part and the most important part about an imaging biomarker is the fact that it has the distinct advantage over liquid biomarkers of localizing the disease, which has huge implications in treatment planning. This is the developmental journey of PSMA PET, and I would really not bore you at this point in time. I just wanted to highlight the fact that to many of us, PSMA actually seems like a very recent development, but it has been nearly 3 decades since PSMA was first characterized in prostate cancer cells, and more than 10 years since 68 gallium PSMA-11, the most widely used agent, was developed at the German Cancer Research Center. So the knowledge generation is really taking off exponentially now. Now, fast forward to today, we now have very high level evidence consolidating the superiority of PSMA PET in staging intermediate to high risk prostate cancer from this SRMA that our group has pushed out. So okay, PSMA PET has established its role in detecting accurately early, previously unseen microscopic disease, much like that exercise of finding Wall-E at the fun fair, to those of you who know this children's classic. But is it good enough at seeing the morphology of Wall-E? While its performance in disease detection outside of the prostate needs no further convincing, a natural question to follow would be, and a practical one actually, would be how does it perform when it comes to detection and localization of the primary tumor? Now, kudos to Prof. Stricker, who is probably here with us, and his wonderful team from Australia for leading the seminal landmark primary study demonstrating the additive value of PSMA PET in the space of prostate cancer detection. Now, beyond an improved negative predictive value and sensitivity, we see that in the primary study, PSMA findings also help clarify men with equivocal MRI lesions. So the primary study has paved the way for more studies to explore primary cancer detection with PSMA PET. Localization by PSMA PET also means that we can potentially base our targeted biopsies on a PET scan alone. But however, as you can see from this study, the performance of PSMA PET-based prostate biopsy still trails behind MRI targeted biopsy. And the urology community got bolder and bolder. And we started asking provocative questions of whether we can diagnose cancer without a biopsy. Now, this study shows how combining P4, P5 lesions on an MRI with an SUV max lesion of above 8 on PSMA is able to detect 98% of Gleason 7 disease and above. So this is data from our own center looking at 123 lesions in 53 consecutive patients who had both MRI and PSMA PET prior to a radical prostatectomy. And we analyzed the accuracy of PSMA PET CT, multiparametric MRI, alone and in combination within a lesion-based model with hormonal histological correlates. And what we found was very similar trend here. With rising SUV max and a higher PIRATs, the probability of detecting significant cancer and more aggressive cancer increases. And remarkably, there was no grade group 1 disease that can be detected when you combine a PIRATs 4-5 parameter with SUV max of more than 8. This table again summarizes the performance of NPMRI and PSMA PET individually and in combination. And what you can see here is that combination of both offers the best specificity with a positive predictive value of 93.2%. So we wanted to round up the available data globally on synchronous use of PSMA PET and MRI in the early detection of prostate cancer. This is unpublished work from our group, again, looking at exactly this research question. Would combining MRI together with PSMA PET improve the detection of clinically significant prostate cancer? Can combined imaging replace upfront prostate biopsy? And lastly, how should we perform and interpret combined imaging? So we've looked at 10 prospective and 9 retrospective studies, all of whom had histopathological correlates, and all had PSMA PET alone as well as MRI alone imaging. So what we found was that combined imaging has a higher sensitivity and positive predictive value than NPMRI or PSMA alone. And a higher positive predictive value implies that a positive finding is more likely to suggest clinically significant prostate cancer, and therefore it makes combined imaging an effective pre-biopsy triage tool. Now conversely, a higher sensitivity suggests that a negative value safely rules out clinically significant prostate cancer, and that men can be excluded from biopsy based on the scan findings. Now putting this into numbers, now the specificity can be alternatively interpreted as the number of unnecessary biopsies that can be avoided. You can see that for combined imaging, the number of missed clinically significant cancer is the lowest. We also looked at this decision curve analysis. So what we found, I mean, it's quite an abstract concept, but except for a small range of very low thresholds, performing biopsy on men with positive findings on combined imaging is definitely more beneficial than a strategy or upfront biopsy. So in conclusion, with higher lesion level sensitivity and negative predictive value, combined imaging can potentially mitigate the risk of inappropriate patient selection and treatment failure in focal therapy. So what we're really saying here is it potentially offers better selection and a reduction of outfield recurrences. So walking the talk, this case, thanks to a colleague of mine, Professor John Yuan, this is a recent case that he's done, a patient who had combined imaging, both MRI showing a very bright, prominent Pyrex 5 lesion and a very hot lesion on a PSMA PET. Now, for various reasons, the patient did not want to proceed with a biopsy, instead went straight for a radical prostatectomy, and the final histology shows and confirms a grade group 2 disease, high risk PT3A, margins negative. So again, a recent multi-center study led by Prof. Stricker, looking at how PSMA PET could value add above and beyond conventional workup of MPMRI and biopsies in selecting patients for focal therapy. Now, this had illuminating findings. They looked at 138 patients who all met focal therapy criteria for hemiablation, and these ROC curves displays the differences in the diagnostic accuracy. You can see that the highest performance actually comes from combined imaging. PSMA PET MRI resulted in significantly improved diagnostic accuracy and detection compared to just MRI alone or MRI plus biopsies alone. And this diagram elegantly shows how a patient with a P5 lesion on the left but an MRI invisible or missed lesion on the right, which was subsequently detected by PSMA PET, would have otherwise been selected for a hemiablation. Now, final pathology also revealed that and confirmed that there were bilateral grade 2 lesions. So again, the study confirmed that the addition of PSMA PET to MRI and biopsies identified nearly half of patients who were not suitable for hemiablation focal therapy on final histopathology, and this was confirmed on final histopathology. So therein lies the additive value of PSMA PET when it comes to focal therapy patient selection. Now, but there are inherent challenges with PSMA PET. We recognize that. It excels in metastatic disease, recurrent disease. However, when it comes to the prostate, it actually has lower spatial resolution, and this is really, really constrained by the PET component. And we know that for the PET component, the resolution is limited at about 4 millimeters. Another phenomenon which we see with PSMA PET is the partial volume effect. Now, essentially what this means is that the smaller the tumor, the greater the underestimation of the uptake value. And as you can see, the diagrams showing that as the lesion gets smaller, the uptake is grossly underestimated. Now, here we are talking about using SUV max as a predictive prognostic biomarker, but because of the partial volume effect, this may limit its value. So is PET MRI the answer to the spatial resolution problem? So before I start talking about PSMA PET MRI, I have a disclaimer. We do not have PET MRI yet, but what we can do is look at the information gleaned from early studies. Now, coming back to our diagnostic test accuracy, SRMA, we uncovered interesting findings with regards to the comparison of synchronous PSMA PET CT and MRI versus a PSMA PET MR. Interestingly, synchronous reading was found to be significantly more sensitive than PSMA PET MR. And we are the first to make such an observation, and we postulate that this could be attributed to the differences in the respective reading and reporting criteria. So again, when it comes to synchronous reading, there are strict definitions both from the MPMR reading as well as with the PSMA PET. But when it comes to PSMA PET MR, there's actually no validated and no standardized scoring system. So this is, and along with other variations in real-life practice, for example, acquisition, MRI pulse sequences, interpretation, reader experiences, this has resulted in PSMA PET MR having a lower performance than synchronous read at this point in time. So I'd like to end off with the last few slides on some future perspectives. So our SRMA has shown synchronous reading to be superior as a triage, but it's important to address the limitations of PET MR early so that we can improve the performance as the experience with PET MR builds up. Separate imaging is definitely more widely available, and we should actually learn from the current available evidence on how to use that. But moving forward, it's important also to harmonize the standards of interpretation. And this is brilliant work by Louis Ahmed and team, just hot off the press of J. Euro, where they push forth the concept of a composite P-score, incorporating both NPMRI PIRET score with the primary score from PSMA PET. And you can see that the P-score here is very, very well calibrated for grade group 2 and 3 disease. So this may be the way forward when we're talking about combined imaging. The second thing is marching PSMA forwards. Now I draw a parallel of the evolution of PSMA to the treatment landscape of metastatic prostate cancer. Now we've seen agents come from right at the back, right at the end of the classroom, all the way down to the front row. So this is really happening for PSMA PET as well. It's established its role in biochemical recurrence staging, and since then it's inched its way forward in our treatment journey and landscape. So I think we really need to embrace this trend and learn as much from what the data that we have right now. Another perspective I would like to share is beyond just localizing and detecting the cancer, is it time to use it as a biomarker of treatment response as well? So I draw a parallel again to metastatic prostate cancer. SUV max is now, has now been shown to be a good prognostic biomarker when it comes to progression-free survival and some survival data. Would that be similar for focal therapy? So it has already been shown based on this abstract. You can see that SUV max, SUV ratio, and even the primary score has been shown to predict biochemical response and treatment failure at 12 months post-HIFU. And lastly, PSMA may not be everything. So this is an interesting study. It looked at a different receptor, gastrin-releasing peptide receptor. It's actually a neuropeptide receptor, but what's interesting about it is compared to PSMA, is overexpressed in low-risk prostate cancer. So can it help better select patients for focal therapy? Now, as shown in this phase 2 study, it has the potential to do that. As you can see on the diagram on the right, the GRP receptor actually picked up a low-risk cancer in some of these patients outside of the treatment field. So what they're postulating is maybe using various different receptors can sharpen the selection criteria for focal therapy. So some concluding thoughts. I think PSMA PET can offer additive value in our prostate cancer diagnostic pathway. Beyond staging, it has a role in guiding triage of biopsies and even for focal therapy. Now, synchronous read of PSMA PET and NPMRI still outperforms PET's MR at this moment. And it's important to keep in mind there are other radioligands on the horizon that is worth exploring. With that, thank you.
Thanks very much, Kenneth. And so the last speaker of this session before we'll open it up for some questions is Andre Abreu, who will talk about rectal and transperineal biopsies. He's renowned for his expertise in minimally invasive urological surgery, specialising in image-guided procedures, robotic surgery and focal therapy. He's currently serving as Associate Professor of Clinical Urology and Radiology at USC in Los Angeles in California, and he holds the esteemed position of Director of Image-Guided Surgery, Focal Therapy and Artificial Intelligence for prostate cancer at USC. So thank you very much, Andre.
you so much for the kind introduction. Thank you for inviting me. It's an honor and a pleasure to be here. Talking about transperineal versus transrectal prostate biopsy, if there is an implication of the methodology of these biopsies for patient selection for focal therapy. Not pressing. Okay. These are my disclosures. Okay, so prostate biopsy, it's very important because if we have an accurate diagnosis, we can have a appropriate stratification and tailor the treatment appropriately for the patient. This is very much a concept of focal therapy versus active surveillance versus radical treatment. It's a very fine-tuning decision-making that we can have with biopsy itself. For example, how much lesion pattern 4 would be acceptable for surveillance versus focal therapy? It's 2 millimeter, 4 millimeter, 6 millimeter. Does anybody have this answer? Can the prostate biopsy technique and the pathology interpretation actually impact on our decision when we do things? For example, a patient like this with a PSA of 8, clinical T1C, and 2-cause Gleason grade group 2, 5%, 10%, most of us would be okay doing active surveillance. However, if there is a patient with similar characteristics, of course, MRI may play a role, imaging, and so on and so forth, but with similar characteristics, with 90% of core involvement, certainly most of us would say that this patient would need treatment. So, and what are the chances that these are actually the same patient? Just by sampling, just by interpreting the pathology. So overall, we stratify by grade, clinically significant cancer versus insignificant cancer. This is very rough. Actually, this is way more elaborated, and the treatment is based on several other features. However, again, the pathology, the biopsy, is the only modified factors that we as urologists can actually play a role. Because if we do a biopsy that is more informative and more accurate, actually we impact the entire cascade of staging and treatment. And how this is important? When we go and we actually, this manuscript showing that 13,000 patients that they looked at their radical prostatectomy specimens, exactly showing that every millimeter matters. When we go by percent of 3 plus 4, 4 plus 3, every single increment on pattern 4 impact the patient outcomes. This was also looked by the MSK group in 450 patients when they went biopsy and prostatectomy, showing that every millimeter of pattern 4 found on biopsy actually impact on the adverse pathology. So detail matters. Now, going straight to the randomized clinical trials that were published recently, comparing transperineal versus transrectal biopsy, there are 3 of them. They were more designed or power for infection, but I will not talk about infection, complication, nothing like this. The main thing here is detection rate. It's a busy slide. It's just to summarize. I have everything there for you. Overall, clinically significant cancer detection is similar for transrectal versus transperineal. And there was a misconception that transperineal biopsy would do better. This is not true. The truth is transperineal and transrectal biopsy have similar clinically significant cancer detection. Having said that, how about the details, as we are saying, right? When they looked into the details, and you see the last slide, the last paper, they showed here when we go for anterior or posterior lesions, then they say for posterior lesions, transrectal biopsy may do better. When you go for anterior lesions, transperineal biopsy may do better. So this now is a different concept, saying that, hey, depending on the lesion location, you may have better outcomes in terms of the biopsy. It makes sense, because if you have, let's say, an obese patient with a large prostate, in a small lesion close to the base, for you to do transperineal biopsy, you have to travel 20 centimeters or so. Your precision will not be the same as if you go transrectal, that you are literally facing the tumor. So there are nuances on this. We need more data, but this is one concept that we should keep in mind. When we did this Delphi consensus with the Focal Therapy Society, we asked to 100 stakeholders, specialists in the field of biopsy, and they say, okay, when the lesion is anterior, yes, we prefer transperineal biopsy. When it's posterior, we don't know. Transperineal or transrectal, we don't know which will be better. And we ask apex, mid, and base, they say, okay, apex is good for transperineal. Mid and base, we don't know. So we do not have much data. I think the data is coming out, and the experts actually don't agree yet. We looked into the data on this in a large cohort, a diverse cohort, with ethnically in different races of 1,400 patients who underwent transperineal transrectal versus transrectal biopsy, all done by a single operator or single institution. So you cannot generalize, but at least we know that the protocol is the same for every single patient. And when we checked, there was some difference in terms of cancer detection rate, clinically significant cancer detection for transperineal versus transrectal, but there was no difference in terms of cancer location, anterior versus posterior in our series. When we adjust for all the confounding factors, number of MRI lesions, lesion size, and so on and so forth, the approach, the transperineal versus transrectal biopsy, there was no difference. Again, transperineal versus transrectal biopsy, no difference. And don't keep the basics that Black or African Americans have increased risk of clinically significant cancer. That's the goodness of studying on a multiracial cohort. Moving forward, we found this. Actually, the transperineal biopsy has larger cancer core involvement, larger cancer core length, and larger cancer core percent. And we looked at this data in and out, right and left, several ways, and adjust for all the confounding factors, and still transperineal biopsy provides a better cancer or greater cancer core length and percent than transrectal biopsy. And therefore, it's more histologically informative. I think this is very important because, again, we are talking about details. So this is one thing to keep in mind. Not only us, this manuscript is quite interesting. This was inpatient randomization. Same patient, they did transrectal and transperineal biopsy, both, inpatient randomization. And they also found that the transperineal biopsy shows a larger cancer core involvement. So how would that be possible? The theory, the hypothesis is that the cancer rises from the peripheral zone, and then they spread over the peripheral zone, craniocaudally and laterally, before it actually goes to the transition zone, right? If this is the case, then that would be an explanation for that. So, in fact, when we looked at the cancers rise, so the heat mapping for prostate cancer, vast majority of prostate cancer rise from the peripheral zone. This is not new for anybody. 80% of them are from the peripheral zone. Now, the target, the way we sample transperineal biopsies, we sample the peripheral zone as well. We don't sample routinely the transition zone, or when we do, only few cores. So we are actually going to the gold, right? And this manuscript, published quite a few years ago from Dr. Villes, actually shows this. They analyzed and they proved that they showed that the cancers arise from the peripheral zone and they spread over through the peripheral zone. So then everything now makes sense. That's why transperineal biopsy has greater cancer core involved than transrectal. And this would be something to consider when you're doing your biopsy. Of course, more data is needed, but this is something that is out there. Second part will be, would be a difference in terms of transrectal versus transperineal biopsy and radical prostatectomy specimen, right? At the end, we want to be accurate. We want to know what a prostatectomy specimen shows. So we looked this into our data, and we looked at two things. One was grade group concordancy in transperineal versus transrectal and prostatectomy, and tumor size on cancer core involvement versus a prostatectomy. And it's a busy slide, but overall, concordance rate for transperineal biopsy, Gleason grade group, a concordance rate was 70% for transperineal versus 56% for transrectal. Grade group upgrading was 13 for transperineal versus 31 on transrectal, and downgrading was 16 for transperineal, 11 for transrectal. That means transperineal biopsy correlates better with grade group on radical prostatectomy specimen with less upgrading and downgrading. And this was all adjusted for multivariable analysis and all the confounding factors, and this is still valid. Now, in terms of size, again, the transperineal biopsy correlates better in terms of size than the transrectal biopsy with the cancer volume on radical prostatectomy specimen. It's not a great correlation, it's moderate, but it's better than transrectal, which is a fair correlation. One thing to be aware when doing transperineal biopsies is the chance of oversampling. So when there is a lesion in the mid of the prostate, in the apex of the prostate, then you biopsy, you get several cores that are positive. If this happens specifically if the prostate is small. So don't exclude those patients from focal therapy based on the number of biopsy core involvement only, right? Now we can't separate all the parameters, imaging and so on and so forth with the histology. So that's why it's important for us to have some mapping and incorporate the imaging. We know MRI underestimate the lesion, the prostate cancer lesion. We know that when we add the core involvement and the number of cores, we can better select patients. Now there is some AI softwares that are available to help with this. And just to keep in mind that possibility of oversampling and still combining with the imaging and the other parameters. Then lastly is how the pathologist, the histology information can impact our decision on treating or not treating the patients. First, when there is a lesion, when the several cores come from one lesion, there is a trend overall that people select the highest score. So there is 3 plus 4, 4 plus 3, and 4 plus 4. Then we say, no, this is a Gleason 8, 4 plus 4, and this patient, therefore, is not candidate for focal therapy. It's done. Let's move forward with prostatectomy or whatever. Actually, the recommendation is to use the aggregate. If in a single lesion, there are 3 plus 4, 4 plus 3, and 4 plus 4, likely this patient will not be Gleason 8 at the end. There is component of Gleason 3 or pattern 3 there. So this is the recommendation from the pathologist. Just be aware of this. Do not exclude patients based on the highest index score only. And now going back to the first slide that I showed, now we go for the concept of continual versus discontinuous course. Please discuss this with your pathologist and ask them to provide you the report with continuous versus discontinuous. So this patient is 10% and then 90%. What are the chances that actually this be the same information? So when we looked for continuous versus discontinuous, the pathologist looked into this. The caveat is all transrectal and no MRI error, but still, actually the chance that your needle hit two separate foci versus the same focus but in different areas is actually 80% versus 20%. So when you look at the discontinuous, actually likely this cancer is way larger in 80% of the cases. So keep this in mind when you're selecting your patients for focal therapy. And lastly, I just want to touch base on this. In 2017, if I'm not mistaken, or 16, the American Society of the Pathologists, ISO group, they recommended reporting cribiform. And please talk to your pathologist to notify you to report cribiform. Cribiform is an aggressive disease, and when we go to further details into it, like percent of cribiform, small cribiform versus larger cribiform, then the things become even more informative. So details matter, and I just wanted to deliver this message to you. Thank you.
Thank you very much. And Dr. Abri, maybe have a seat up on the, and if the previous speakers would be kind enough to come and join us up on the panel. We are running a little late, but we've got 5 or 6 minutes for questions. So certainly want to open it up for any questions from the floor, if there are any at the moment. Thank you.
A question for the last speaker. I'm a radiation oncologist, and I'm surprised that we're still debating transperineal versus transrectal biopsies. I thought the answer was quite clear. Maybe I'm not, I'm unsure of some of the operational issues that may make it difficult for all of us to do transperineal biopsies, but I thought transrectal should be confined to history now. Transperineals don't cause or have a negligible sort of risk of sepsis. There is no death. And we're also facing a world whereby we have increasing microbial resistant E. coli and even the development of carbapenem resistant E. coli nowadays.
I agree with you. I do transperineal biopsy exclusively currently. I just do transrectal when patients ask, some patients that are on surveillance, they say, yeah, I would like to do the biopsy the way I was doing. However, with these manuscripts that I showed, 3 of them showing that the cancer detection rate is similar and infection rate is somehow similar, is still debatable. I think we have a way pushback, and I can tell you that will be way harder for us to convince the urologists in the US to tell them that transperineal biopsy would do better than transrectal with this data that I just published. That's my feeling, but I agree with you.
Philip Stricker.
2 questions. First of all, on micro-ultrasound, it was a great talk, thank you. I was just wondering what the inter-observer variability and interpretation and the learning curve is on that. And just with regard to PSMA PET scan and your comment, your 4th comment in your conclusion, where you talked about the new ligands, do you think the new ligands, such as the copper ligand, will improve below 4 millimeters the resolution of PSMA?
Thanks, Phil. So I'll take the first part of the question on micro-ultrasound. It's a new imaging modality, right? Micro-ultrasound. There's not as much expertise with micro-ultrasound. We don't know as much. It's where I would say MRI was perhaps, 5, 7, 8 years ago. There have not been too many studies, but there's been one study looking at inter-reader variability on micro-ultrasound, a very recent study, and it did not do as well as MR. But I think it's really the early stages, especially more in the transition zone. The primus, which is the scoring for micro-ultrasound lesions. And when we came up with the primus score, 1 to 5, higher the score, higher the risk of cancer, we were actually just emulating and trying to do what PIRATS had done for MRI. But it did not initially incorporate transition zone. The primus version 1, as I would say, was only for the peripheral zone. And I for time restraints, I didn't talk about primus here today. The scoring pattern from transition for the transition zone is very recent, and I think there's going to be a learning curve, and it might take us a while to be where MR is, but I think it's got that potential for sure.
Thanks, Prof, for the question. I must confess I don't know much about the new ligands as yet, so I'm probably not the best to be able to comment on that. But I think when it comes to ligands, there's a lot that can be done. For example, the excretion of the ligands actually, different ligands have different excretion mechanisms, and we know that renally excreted ligands can actually interfere with interpretation at the prostate level. So this is one of the fallbacks of some of those renally excreted ligands. But when it comes to the spatial resolution, I don't know enough to comment on that, but I think at the end of the day, it's really very much still limited by the PET component.
Thanks. Shelley?
A statement or question to Andre, please. we still see infections with TP biopsies. It's not perfect. So you can go through the rectum and still cause problems. So I see your point. The second question is, crib reform, what's your cutoff? What do you do for your focals? Sorry, I know it's difficult.
It's a difficult question. In terms of cancer resistancy or resiliency locally to the energy, whatever energy, I'm not going into details of energy, the cell should be destroyed, right? We should destroy the cell. They should be gone. However, the disease itself is still a higher risk disease. All the microenvironment, all the micrometastases that are potentially there or not, and so on and so forth. So this is the concern. I didn't put a case. I had a case. I didn't put it because I didn't have time. A patient that I did, and that's why I emphasized the cribiform. I did a cryoablation on this patient 5 years ago. He had a cribiform. At that time, we, building some more knowledge on this, maybe 5 or 6 years ago. And everything was fine. Was a Gleason 7 cribiform, perfect candidate for focal therapy. 5 years later, his PSA rose from 1 to 4 in about 5 to 6 months, and then to 5 and rising. Bad PSMA with metastasis, a tiny little cancer on the prostate specimen only after prostatectomy. So, everything looked good, but the disease was probably bad from the very beginning. And that's the thing with the cribiform. I don't know how to answer your question, but I would be more careful.
Well, I might use moderator's privilege to ask the last question before we break for morning tea, really to the whole panel. Have we reached a point with focal therapy where if you have a MRI negative lesion or something that is very difficult to see, but is seen on PET or seen on micro ultrasound, can we still actually deliver focal therapy in that setting? Or I'm just interested in the experience of the group. I've certainly had a number of patients that have had very difficult to see lesions on MRI that are very obvious on PET PSMA. And it's always a very difficult decision about what we do when they're truly unifocal.
So, most of the programs that I'm involved in are actually MRI-guided in-bore focal therapy. So for that, we do want MR visible lesion for sure. And I think if you're going to be ablating MR invisible lesion, it's very difficult to know where to stop your margins, right? So it has to be a fairly sized ablation rather than a targeted kind of an ablation. In our practice, we generally do not do that. And of course, we haven't used micro ultrasound as much for focal ablation, but we're starting a phase 1 study very, very soon, actually, for ablation using laser under micro ultrasound visible lesions.
Can I just add about that? Okay, so in addition to planning treatment, I think as a radiologist, you have to think about surveillance. So if you can't see on ultrasound, I can't see how I can help you follow up the patient if you're going to do MRI for surveillance. And the other question about cribriform is that it has been shown in many papers that cribriform architecture tumors are usually very occult on MRI. So you can't even see the primary tumor that well to begin with to ablate it. So in subsequent surveillance, I think it's going to be painful for everyone. And by the time we see something, it might be too late. So that's something to think about.
Terrific. Well, I think if we could all show our appreciation to all of our speakers this morning. And terrific talk. And we'll have the tea break in the exhibition hall in the next room, with the next session being at 10:15. And I thank my co-moderators as well. So thank you very much.
Thank you, Vaughn. Thank you, everyone. Just making an announcement for the FTS board members. Please gather on stage for a photo before you head out for the break.